Hello everyone. Today we are going to start up with diseases associated with the excretory system, and to be precise, related to the kidney and associated structures. But before we start up with diseases of the urinary system, we should first have a look at the test which actually determines that there is some problem associated with the excretory system. And to start it, we will have a detailed discussion on renal function test. But before we start with the test which we need to conduct, let us have a brief introduction about the urinary system or the kidney. There are two kidneys in our body which lie retroperitoneally on each side of the vertebral column, slightly above the level of the umbilicus. This you might have gone through in your anatomy lessons. The approximate length and weight of kidney is around 6 centimeters in length and 24 grams in a full-term infant, and approximately 12 centimeters and 150 grams in an adult. Both the kidneys contain their functional unit as nephron, because as the kidney will have this function of filtrating the blood and taking out the excretory substance or the waste from the blood, and helps to filter the blood and take out these substances which are not used by the body or are harmful to the body, and it would be moved out of the body. So there are approximately 1 million nephron in each kidney. In humans, formation of nephron has completed approximately to the 36th week of gestation, but functional maturation and tubular growth and elongation continues during the first decade of life. So it does matures and grows in size even after the birth. Because new nephrons cannot be formed after birth, so any disease that results in progressive loss of nephron can lead to renal insufficiency. So we don't have the regenerative capacity of nephrons, and that stands to be a limitation, as any cause which is adding to the loss of nephrons will lead into renal insufficiency. A decreased number of nephrons secondary to low birth weight, prematurity, that is premature birth, or any unknown genetic or environmental factor is hypothesized to be risk factor for the development of primary hypertension and progressive renal dysfunction in adulthood. And let us understand about what is the parts of the nephron. The outer layer, the cortex of the kidney, would contain the glomeruli, proximal convoluted tubule, and the distal convoluted tubule. As you can see, uh, the cortical and the medullary region of the kidney has been demonstrated in this diagram. Also, collecting duct is present in the cortex region, whereas the inner or the medullary region contains straight portion of the tubule, also the loop of Henle, vasa recta, and the terminal collecting duct. About the details of these parts, we have already understood in the chapters of physiology. There is one more important structure present in the nephron that is known as GG apparatus. or the juxtaglomerular apparatus. The cell of the distal tubule and the part that comes in contact with the efferent arteriole of the glomerulus are more dense than the cell in the rest of the tubule and is known as the macula densa. The smooth muscle cell of efferent arteriole that approximate macula densa contain prominent secretory cytoplasmic granule which are the site of renin activity. This GG apparatus is composed of the afferent and efferent arterioles, the macula densa, and the Lacus cell located in the triangular space in between these structures. It is involved in the systemic blood pressure regulation, electrolyte hemostasis, and tubuloglomerular feedback mechanism. So overall, the function of the nephrons and also the flow of the blood towards the nephron would be directly or indirectly controlled by the GG apparatus. Now about the vasculature or the blood supply of kidney. Renal artery rising directly from the abdominal aorta divides into fine segmental arteries. This later will divide into interlobar arteries which branch into the arcuate arteries near the junction of the cortex and medulla. Interlobar arteries provide the efferent arteriole for the glomeruli. The glomerular capillaries join to form the efferent arterioles that lead the glomerulus and forms an extensive network of peritubular capillaries that surround the tubules, mostly in the cortex and also in the medulla, to form vasa recta. The vasa recta, along with loop of Henle, are responsible for urine concentration. As we will see, what is a function of the nephron, we divide the function of nephron into ultrafiltration, excretion, and reabsorption and secretion. So, and both this part, that is the reabsorption and secretion part, is enabled by the presence of vasa recta. This is a structure and function. And we have already seen into the structure of the nephron, into the various parts, and to understand the function, that is into the three functions, that is filtration, also better known as the ultrafiltration. This filtration is at the level of glomeruli, where uh, the pressure forces water and dissolved substance from the glomerular blood into the Bowman's capsule, and which is approximately 125 ml of blood gets filtered, or the filtered substance comes into the Bowman's capsule is around 125 ml per minute. But this great amount of filtrate needs to be reabsorbed for the important substances that are required by the body, because here the filtration is occurring for the all the dissolved substance. So what happens is it's a reabsorption of the essential substances, the return of substance from the filtrate to the blood, and interstitial fluid like water, NaCl, that is sodium chloride, both individually sodium and chloride would be absorbed in the form of their ions. Glucose amino acid is taken up by active transportation, as these are essential substances. So we do spend energy on them, so it's an active transportation. Also, secretion occurs, the active release of substance by tubular lining cell into the nephron tubule, and gets rid of the toxin substance like urea, creatinine residue, electrolyte balance, mostly releasing potassium and carbon in the acid base. It also maintains the acid base balance by releasing H plus and ammonium ions. So in this diagram, I have gone through this. This is vasa recta, which will help in the reabsorption and secretion. And at various levels in the nephron, you see there is an exchange of water and the important electrolyte and the waste in and out of the nephron. Have a closer look at this. You'll understand how the function of nephron is done. Now we come to the diagnostic evolution. The diagnostic evaluation of renal function test is done by, first of all, the urine examination, that is both routine and microscopic. Also, evaluation of renal function is done at various levels. Renal biopsy and imaging techniques are also used to confirm the dysfunction of the kidneys. Now, let us start with the urine examination. It is the most important step for the diagnosis of renal diseases. Now, we have steps for it. And how do we do it? Is sample collection, first of all. The first morning specimen is preferred. That is the first routine in the morning. It is collected in a clean container, especially designed for collecting the urine sample. For culture, if you want to go for the urine culture to see if there is any infection or not, the specimen should be collected in a sterile container and sent to the lab immediately, where it should be plated within 15 minutes or stored in a refrigerator at 4 degrees Celsius, as bacteria do multiply rapidly at room temperature, which may give false positive result. So what is false positive result? Then is there was no infection, but due to delayed examination or testing the sample, it gives rise to some other bacteria and it may give a positive result that the person is having bacterial infection. Now, what are the methods for urine collection? Uh, a clean catch midstream specimen, that is, when the person is urinating, it's not the first sample. Have we need to collect the midstream or in between the urination or maturation. We need to capture that. In older children who can cooperate, midstream specimen is obtained after proper local cleaning. The initial part of the urine is discarded. Bag collection in neonates and infants. Urine can be collected in sterile bag, not used for microscopic examination. Also, bladder catheterization. A urine specimen can also be safely obtained in infant by strict bladder catheterization, which requires some skill and experience. And suprapubic bladder aspiration. The only reliable way to obtain reliable urine specimen in neonates and young infants, and in children less than 2 years of age, it is the most suitable method for defining definitive diagnosis of UTI. Now, the urine routine examination, what we need to look into this examination. First is a specific gravity. Full term infants have a limited concentration ability with a maximum specific gravity of 1.021 to 1.02. It is measured with a clinical hydrometer. Increase in specific gravity be assessed with be associated with dehydration, diarrhea, messes, that is vomiting, excessive sweating, etc. While decrease in specific gravity may be associated with renal failure, diabetes insipidus, interstitial nephritis, and excessive fluid intake. And also, ETN is its hypertension. pH. pH is tested with pH meter. Routine lab reports of pH are of no importance. UTI with urea splitting organism make urine highly alkaline. Normal pH range from 4.6 to 8. In fasting, the concentrated urine sample is highly acidic. So these are the pH. This is the pH range. How we define pH. It's around 4.6 to 8. But where some organisms can make it alkaline, and the other condition can make it too much acidic. A high acidic urine may be due to UTI, vomiting, and a low urinary pH may be due to ketonuria, diabetic ketonuria, diarrhea, and starvation. Also, we do test for presence of protein. Boiling test is the first way of assessing the presence of protein in urine. What we do is 10 to 15 ml of urine is taken in a test tube and upper portion is usually boiled. If turbidity appears, 3 drops of concentrated acetic acid are added and specimen is boiled again. And we do grading from 0 to plus 4. Now what does 0 stands for and what does plus 4 stand for? So in a report, if we are actually seeing into a physical report, that is a printed report, we see plus marks written in it. The protein is plus one. A single plus would be drawn, or a double plus, or a triple plus, or 4 plus. So what is the inference of that? If we have a single plus, it is presence of light turbidity through which print can be read. It's around 30 to 100 milligrams of protein per deciliter. Plus 2 turbidity with slight precipitate, 100 to 300 milligram. Plus 3 white cloudiness with fine precipitate to which black lines are not visible. It's 300 to 1000 milligrams. And plus 4 is large clumps of white precipitate. It is more than 1 milligram of protein per deciliter. Also, there is a dipstick method. Example, one of the example is heuristic. There is a trade name used, widely used to test for proteinuria. It's more convenient and equally reliable. Color changes from yellow to green. Light chain protein and low molecular weight tubular protein are not detected by this method, and the taste reacts. What does the urinary pattern or the change in the color can be designated? Again, same chart or the same method of designating it as a plus 1, plus 2, plus 3, and plus 4. Proteinuria in patient with nephrotic syndrome, one of the disease associated with kidney, is massive, that is ranging between plus 3 and plus 4 by dipstick, and selective constituent predominantly of albumin without loss of protein of high molecular weight. In presence of tubular damage or physical injury to the glomerular barrier, the proteinuria is non-selective. That is, you won't see a selection of low weight and high weight, or all types of protein would be seen. In renal parenchymal disease, proteinuria is often quantified to assess degree of glomerular injury. That is, selective proteinuria, intermittent size or size that is less than 1000 kilodalton of protein, albumin and transferrin leaks into the glomerulus, whereas in case of non-selective proteinuria, different size protein leaks through, including large proteins like immunoglobulin. So that is all about the protein. Quantitative measure of urine protein. Accurate collection of urine over 24-hour period is required to quantitate protein excretion. A value of more than 4 milligram per meter square per hour is considered abnormal, and anything more than 40 is indicative of heavy proteinuria. A range proteinuria in nephrotic syndrome is massive. It's more than 3.5 grams. per 24 hours, while the range in nephrotic syndrome is mild to moderate proteinuria, it's less than 3 grams per 24 hours. Now, the urine protein and creatinine ratio, an approximate estimate of severity of proteinuria, also can be made by measurement of urine protein and urine creatinine from random urine sample. So ratio between the urine protein and creatinine, if it's more than 2, indicates heavy proteinuria, and if it's less than 0.2, it's insignificant. Such measurement are of use in following response to a therapy in various disorders, but seldom necessary in children with nephrotic syndrome. Apart from protein, we also look into the presence of glucose, like the older methods of using Benedict reagent or the Benedict test to detect the reducing substance. Nowadays, it has been replaced by the dipstick test, and it's based on glucose oxidase peroxidase linked reaction. So we can assess whether the given sample is containing glucose or not. Also, we do have a detection for blood. Detection of hemoglobin by dipstick is based on a reaction with a spotted positive reaction indicating intact red blood cell and uniformity positively suggesting presence of free hemoglobin. However, the use of dipstick to detect hematuria is discouraged because the reaction may often be false positive, as in the case if it's showing presence of myoglobinuria, oxidizing substance, bacterial colonization, or false negative, as in cases of ascorbic acid and other reducing substances. Apart from the blood examination, microscopic examination also becomes important. It is to see microscopically what all is present. A fresh, well-mixed specimen should be used. Presence of cellular elements and cast should be noted. That is, in cases of uh, renal calculi, we may see some cast or substances shed from the lithium substance or the stone. Red cell cast indicates, if we see red cell cast, it indicates glomerular inflammation. So in this case, we can see red blood cells in the patient with glomerulonephritis. Slide presentation, microscopic slide presentation. We also see white cell cast with clumping of neutrophil that might suggest of acute pyelonephritis. Epithelial cell cast are noted in patients recovering from acute tubular necrosis. Also, hyaline or fatty cast may be present in proteinuric state or in normally in individual concentrated urine. Red blood cell and leukocytes can be counted under the high power field and more accurately in counting chamber. More than 5 leukocytes along with bacteriuria such as urinary tract infection. Neutrophils may also be detected in proliferative glomerulonephritis and interstitial nephritis, while the presence of eosinophil in urine is specific of acute interstitial nephritis. So we come to know that by observing different things, different substances microscopically, like RBC is present, or more than 5 leukocytes are present in high power field microscopy, or if eosinophil is present, then what can be the influences? Hematuria is defined as presence of more than 5 RBC in a centrifuge specimen in a high power field. RBC morphology is useful in distinguishing between glomerular and non-glomerular cause of hematuria. The site of injury is likely to be The lower tract, lower urinary tract, if 20, less than 25% urine correlates well with the colony count of over 10 is to power 5 organism per milliliter, indicating significant bacteriuria. This as a count, less than 25% of urine is actually giving you an exact colony count of bacteria. So we come to know that what is the site of injury after this. After microscopically assessing the urine, we also have the process of urine culture, which is usually done in order to assess which type of organism is actually affecting the UTI or the person suffering from UTI. So, diagnosis of UTI. So what we have is how many organisms would be usually found, and what is the likely assessment or the probability of an infection. So, as we have seen, different methods of collecting the urine sample. The one was suprapubic aspiration, which was very specific and very uh, highly accurate. So, any number of colony count, any number, there is even a smaller number, will also give you an exact estimation that the infection is present or not. In case we go for urethral catheterization, if it's more than 10 is to the power 5, and 95% chances that there is an infection. If it's between 10 is to the power 4 to 10 is to the power 5, it's likely that it is there. 10 is to the power 3 to 10 is to the power 4, suspicious, and we need to repeat the culture. And in case it is less than 10 is to the power 3, then we can have the result as negative. Whereas midstream void method, if it's used in boys, it should be more than 10 is to the power 4, and in girls, it should be 10 is more than 10 is to the power 5. We'll discuss about the renal testings in the second part. We'll see the blood assessment on the toxic substances and also the imaging techniques. Thank you.